I fell in love with the brachytherapy, with the fact that you can treat the tumor so close. We have to take care of the patients. You see it with your own eyes that you can make a good difference in their person's life.
Dr. Alina Sturdza was recently the recipient of the prestigious Strebel Medallia Award for her groundbreaking contributions to MRI-based image-guided brachytherapy in gynecological cancers. As a radiation oncologist and gynecological oncology site leader at the Medical University of Vienna, Alina has become a leading expert globally and continues to significantly impact the field through her clinical practice, educational initiatives, and dedicated research, including the EMBRACE and retro-EMBRACE trials. So let's delve into Alina's journey, her pioneering work, and the future of gynecological cancer treatment. Welcome to this episode of Spilling the RT. I'm your host, Emily Bassett. So when I was an RCT, I did do quite a bit of cervix brachytherapy, and it is an art form in itself. How does adding MR-guided adaptive brachytherapy utilised in the treatment?
Well, that's a big step forward. Because actually MRI is the best imaging modality that we have for the moment for gynecological malignancies, for prostate cancer, for instance, because you can see very well the different types of gray that you usually see on the CT. In CT, you have only one type of gray. In MRI, you see the soft tissue much better, and you can differentiate which areas of the organs are involved with tumor, where is the potential microscopic area where there is a high potential of having tumor cells, but not like a big tumor. And of course, you see very well the organs at risk. So by using the MRI, we can be very precise. First of all, when we get the applicator in, especially in larger tumors, you can also add the different type of needles, either straight needles or oblique needles, in order to cover better the target. And by using the MRI, we see much better this tumor. The target is much better to be seen. Also, the organs at risk are quite well to be seen, but the organs at risk are also well seen in the computer tomography. The difference with MRI guidance is in the target delineation, actually. And we also now plan, in the last 20 years, we planned also on the MR images. So it's a real-time treatment. In the past, we did, at the beginning, we did our implants in the MRI suite. And in special cases that were very big tumors, we put some basic applicator inside the tandem and the ring, and then some needles, and then we took images in real time of the MRI to make sure that the needles are in a good position, and then we repositioned needle or added more needles. So that was really a 4D application, meaning that in real time we adapted our implant according to what we saw in the imaging. Of course, this is possible to be done with CT as well. And now we also use the transrectal ultrasound with the guide for the guidance of the applicator and the needles. But as I said, the MRI depicts very, very well the target, and this is the big advantage of performing the MRI-guided brachytherapy. And as you probably know, in Vienna, there was Richard Kotta that was the PI of 2 EMBRACE studies that were exactly looking at the influence of using MRI-guided brachytherapy in the treatment of cervical cancer on the outcome in terms of local control, overall survival, and side effects, of course, on the organs at risk. And the results are excellent, as you may know.
I do, yeah. And so you would attribute that mainly to the target, so the visualization of the cervix itself.
Yeah, the visualization, and when you know exactly where the tumor is, we also know that there is a certain dose that has to cover that tumor in order to have successful outcome. In terms that basically the tumors are melting away if you have a certain dose. This dose is usually over 85 gray, but most of the time we need to deliver over 90 gray to these tumors, which is a very high dose. I just want to tell you that in gynecological malignancies, the majority of gynecological malignancies are treated with two types of radiation: an external beam component, which is in general coupled with systemic therapy, a concurrent systemic therapy, usually is a chemotherapy that works as a sensitizer, and more recently also an immune therapy in cervical cancer that's also taking care of the potential systemic tumor cells that may have been gone from the primary tumor. And then with this external beam part of the radiation, we deliver in general 45 gray to the tumor. And with the brachytherapy, with 3 or 4 fractions of brachytherapy, we deliver the same dose. So basically, you do the external beam within 25 fractions, so 25 working days, and the same dose it's given in 3 or 4 days. You can imagine that we have to really be very, very precise in order to treat exactly the tumor and to spare the organs at risk. And this is where the MRI guidance make the difference, because as I said, we contour the volumes on this tumor. The rest tumor has a volume. The microscopic microscopic tumor is a volume that we prescribe doses at, and something that we call intermediate risk target volume, which is an area with potential risk of having some malignant tumor there as well. And all these 3 volumes have different doses. Yeah. So that's why with brachytherapy, because it's a very steep fall out of the dose, we can treat with a very high dose, the rest gross tumor volume. With a very good dose, also hide this high risk clinical target volume, and the lower dose around 60 gray, the intermediate risk volume.
Image-guided adaptive brachytherapy. The main idea of image-guided adaptive brachytherapy is to use advanced 3D imaging, ideally with MRI, to personalize radiation delivery to the patient's anatomy and tumor response. This enables clinicians to escalate the dose to the tumor with high precision, minimize exposure to surrounding healthy tissues and organs at risk, and adapt treatment plans over time based on tumor shrinkage or anatomical changes. This technique has become the gold standard in locally advanced cervical cancer, and this has been facilitated by the EMBRACE trials, a series of studies aimed at improving treatment for cervical cancer. The EMBRACE trials are a series of international studies designed to evaluate and improve the treatment of locally advanced cervical cancer using MRI-guided brachytherapy and external beam radiotherapy. EMBRACE 1, initiated in 2008, involved 1,416 patients from 42 centres worldwide. This study focused on MRI-guided brachytherapy combined with external beam radiotherapy and chemotherapy. The results showed significant improvements in local control and overall survival rates, highlighting the effectiveness of MRI-guided brachytherapy in improving patient outcomes. Building on the success of EMBRACE 1, EMBRACE 2 aimed to standardise treatment protocols and further improve clinical outcomes. This study included 1,500 patients from 49 centres with locally advanced cervix cancer and focused on defining target volumes and dose prescriptions for both external beam image-guided intensity-modulated radiotherapy plus cisplatin chemotherapy and MR-guided adaptive brachytherapy. EMBRACE 2 showed significant improvements in disease control, survival rates, and reduced morbidity compared to EMBRACE 1. The study also demonstrated the benefits of standardized treatment protocols in achieving better clinical outcomes. The findings from the EMBRACE trials have been incorporated into treatment guidelines for cervical cancer, solidifying MRI-guided brachytherapy as a standard of care for locally advanced cases. So adaptive radiotherapy is very trending at the moment. So as you say, when you add the MR to real time, this is a form of very much adaptive radiotherapy. And you mentioned the impact that it has, but sort of more specifically, if we think about the outcomes and quality of life for women, what are the slightly more direct impact that women might see from this type of treatment?
Yeah. So first of all, I have to mention to you that actually the local control, so basically the fact that the tumor melts completely, yeah, in lay terms, it's the likelihood is 92% shown by the Embrace 1 and now 93% with Embrace 2 when systematic MRI-guided brachytherapy was used. Yeah, so it's which in lay terms means that from 100 patients with cervical cancer treated with MRI-guided brachytherapy, only 7 of them will have recurrence in the cervix. So 97% of them, and 97% of them, the tumor will be gone, which is amazing. This is absolutely amazing. And with the other types of the brachytherapy that we use, which is called 2D brachytherapy based only on X-rays, this number was lower, around 80%. So it's a huge difference. Because of excellent local control, we observed as well that the overall survival is getting better because you have the primary control for a very, very long time, in many cases forever, and therefore there will be no spread of the disease in the organs like in the lung or the liver or the lymph nodes above this. So it's a very, very good step forward with the MRI-guided brachytherapy.
Great. And I think just sort of sticking with cervix cancer for a minute, and going back to maybe to quality of life a little bit, I wrote a little article on LinkedIn a while ago about the HPV vaccine and how exciting it is for that coming along, but also how important it is not to forget that there's a generation of women who, unfortunately will still experience cervix cancer. So it's really important that these research initiatives continue, because quality of life for women is really important. Actually, quality of life for women isn't an overstudied research topic in oncology in general. What's your take on that?
So what I wanted to say initially is that once the patients don't have a high risk of recurrence, of course they do much better, and their quality of life anyways is much better because they have less side effects with this type of treatment. And as you mentioned, there is tons of literature over there, many papers from the EMBRACE study. Showing the quality of life of the patients and actually which is a very good quality of life, and this is the consequence of good brachytherapy and MRI-guided brachytherapy. And there were actually within the EMBRACE study, there were many new ideas and new ways of determining the quality of life in regards to the side effects of the patient that were developed. And you can even maybe do a podcast on that separately because this is a very broad topic. Now, regarding the HPV vaccination, luckily we have a lot of information about the efficacy of the HPV vaccination in these patients. Almost everybody knows, but I have to mention it here. 98% of the cervical cancer is produced by the HPV vaccination that persists, and it's usually either HPV 16 or 18. These are the most malignant types of HPV that produces cancer. And now we have actually data on the efficacy of the HPV vaccination, not only in gynecological malignancies, but also in anal malignancies and head and neck malignancies. Interestingly enough, patients that have an HPV-based cervical cancer in our case, because we are discussing about it, but this is valid also in other types of HPV related cancer. They have a better prognosis because they tend to respond better to the treatment. However, of course, ideally you don't have an HPV inside you that gets activated at some point. And now we have over 20 years follow-up in the Australian data that shows that actually when women are vaccinated, ideally prior to having their first sexual intercourse, the protection is almost 98% for all these diseases. So I cannot emphasize enough the importance of the vaccination. And lately, also young children, young boys are vaccinated. So because they are the vectors of this virus, because basically HPV is a sexually transmitted disease. We have to say it out loud because that's the truth. And so there are many initiatives. For instance, in Austria, girls are vaccinated at the age of 9 if they want to, of course, and boys starting age of 12. And in Austria, at least, these vaccines are free of charge. And the advantage of getting the vaccines prior to the age of 18 is the fact that you have only 2 vaccines, as opposed to the older age. You have to do 3 vaccines to get yourself covered. Not, and I'm sure this will change because there are studies going on, and actually there is some evidence that even one vaccine is of better benefit than none. In cases that, in countries that cannot afford all the 3 vaccines. And basically, what we also do, because here in my hospital, we have a very strong focus of research on HPV vaccination. And one of our colleagues was involved from the beginning in the development of the vaccine. We also actually recommend our patients that had cancer and that were treated successfully from cervical cancer to take the vaccine as well.
Oh,
Yeah.
really?
Yes, yes, yes. As this is a newer development, and we strongly think, because we think that it makes a difference, because once you have the vaccines, that stays in your body, because almost everybody at some point in life they have the HPV, but luckily over 80% gets eliminated by itself, but the 20% that they could persist forever. And you have many organs that could be attacked by the vaccine. Even if the patient had an HPV related cervical cancer and they are cured, then they can still develop an HPV related vulvar cancer or vaginal cancer. These are more rare diseases, however, they could still happen. So, or a head and neck cancer, yeah. So, yeah, we recommend this.
That's super interesting. And outside of cervix cancer, are there any other gynae indications that can benefit from MR-guided brachytherapy?
Absolutely. Actually, we perform all the gynae brachytherapies MRI guided. We are an important center for vaginal cancer treatment. Vaginal cancer is much less frequent than cervical cancer. Ourselves, we have about 12 a year. Also in recurrences from endometrial cancer. So the patients undergoing hysterectomy due to an endometrial cancer,
Mm.
they could still recur in the what's left from the vagina. We call this in medical term vaginal cuff.
Hmm.
So they can recur over there. And in this setting, we also use MRI guided brachytherapy. In some cases of ovarian cancer with vaginal cuff recurrences, we also use this. They are very rare cases. And we also use brachytherapy with MRI guidance in some cases of vulva cancer that have infiltration of the vagina. So, so basically, in all the entities that we treat here, also now there is a lot of development in the ray radiation setting in patients that were treated in the past, and sometimes you cannot perform external beam because the dose to the organ's risk is so high that you cannot afford to treat again with external beam. And in these cases, we do straight brachytherapy, of course, providing that the tumor is amenable to getting the access to the tumor with needles or applicator, and we do also many cases. I would say it's increasing more and more lately of ray radiation by the means of brachytherapy, not only in gynecological malignancies, but also in some prostate cancer patients or some breast patients.
And Alina, I'm sure you have a huge amount of experience talking to patients. From a patient perspective, are there any important considerations or questions that women should keep in mind when they're exploring maybe treatment options for gynecological cancers?
Um, Absolutely. It's very, very, very important. I cannot emphasize enough that the patients go to centers with experience. Yeah, in treating gynecological malignancies, especially in Europe, in the developed countries. There is so much advanced medicine, but in certain centers, what I call, as I said, the centers of excellence. But the others, because especially in cervical cancer, the incidence of it's getting low, thanks God, and because of the screening mainly, in the next 10 years will be also because of the vaccine. So not all the centers have experience in treating cervical cancer. So the patient should be aware about that and try to go to, in general, university centers in big cities have this MRI guided brachytherapy available. So they have to get themselves informed. Unfortunately, there are still some surgeons that are operating locally advanced cervical cancer that should actually not happen because it is not safe to once the cancer went outside the cervix per se, then there is no role for operation anymore. So that's the most important thing, to let themselves maybe for go for a second opinion, at least in a center that has more experience in treating cervical cancer. That's very important. And one other thing that I want to mention here, in the case of cervical cancer or vaginal cancer, the treatment includes mandatory brachytherapy. Yeah, so there is no way, because I have patients that are afraid about brachytherapy because to them it sounds very invasive. Um, these patients, they need the certain dose in order to keep this local control. Even then, sometimes through external beam and systemic therapy, the tumor melts away, at least in imaging. We have evidence from the EMBRACE studies that this tumor needs a certain high dose of radiation to stay in complete remission. And therefore, brachytherapy is not optional in the treatment of cervical cancer with an intact cervix and uterus, the same with vaginal cancer. So they need the brachytherapy treatment. They should actually get himself very well informed, because there is a degree of anxiety when the patient hear about brachytherapy. It happens almost in every single patient. But then they should talk to the doctors, and they should try to understand from the doctor how the brachytherapy is performed and how good the results are with brachytherapy. And of course, there is also potential with an invasive application, let's put it this way. But that's why it's very important to go to an experience centers, because with experience, the likelihood of something going wrong is very low.
Yeah, and I think, as you say, I think part of patients hopefully feeling a bit better about it in the future will be that more people know about brachytherapy, and not just those who, are sort of faced with it when they have a diagnosis. Is that something that you hope does increase and improve in the future? And do you also see brachytherapy continuing to evolve for patients?
Absolutely. As I told you, in the last 20 years, at least in gynecology, but also in prostate cancer, there is a lot of involvement in the brachytherapy. Now there are new areas that we treat. There is a high increase in the use of brachytherapy in gastrointestinal tumors, in skin tumors now. Uh, it's less maybe in breast at the moment, because the external beam it's making a lot of steps forward by increasing the dose on the fraction. But there is also still a place for ray radiation with brachytherapy. So I particularly am a strong believer in brachytherapy. And actually, through the Jack Astro Hero, we plan together with the Brachytherapy Consortium, including the American Brachytherapy Society, the Indian Society, Australian Society, to re-implement the Brachytherapy Awareness Day, which happens on the 17th of July. And we are working strongly now on our first campaign together to raise awareness of the brachytherapy in general, and hopefully will be successful. Now we are also working with patient advocates groups to make them aware of the brachytherapy, because many of them they didn't know about brachytherapy in the past. So we involve them a lot in our work, and we organize meeting with them, and we try to present brachytherapy to this patients group. So I think brachytherapy is a very efficient method of treatment. Definitely has a very good efficacy on the local control, and with this MRI guidance, and in some cases with CT guidance, spares a lot the organs at risk. So it's a very, very good treatment, and I think we really have a future. Brachytherapy is the oldest type of radiation treatment. It was used before the Linux, the external beam happened. So and although everybody thinks that at some point will disappear, I see it growing and growing and evolving a lot. And now with our initiative of teaching and building up the new generation of brachytherapies, I think this will flourish further. That's my own impression.
That's great. That's actually going to be my next question. I was going to say, because brachy can be quite niche, and I know some people have an opinion it's not going to be around in the future. So you've just said it is going to be around in the future.
Yeah,
Um,
yeah.
and I guess related to that, we've been talking about EMBRACE and EMBRACE 2 quite a bit about cervical cancer. Is there any other ongoing research in brachytherapy at the moment you think's particularly exciting or promising outside of EMBRACE?
Yeah, I mean, we continue with Embrace 3. So that's a registry study. I mean, Embrace 3 has about 5 studies actually. So we are evolving in the area of personalized medicine. So there is first of all there is the registry study that looks at MRI-guided brachytherapy in real-world settings. So basically, consecutive patients will be enrolled, and then plus the systemic therapies are still controversial. So we'll admit everything with the mandatory thing that they have MRI-guided brachytherapy to a certain dose, of course, according to the Embrace 2 protocol. And then we also have, with the focus in India, the city-based brachytherapy, because we acknowledge the fact that where the cervical cancer incidence is higher, they don't have the facilities and the possibility of performing MRI guided in every single patient. So that's a second study. And there is the rewind study that looks at the 2 years between the finishing the Embrace 2 and starting the Embrace 3, also real data. And then there are 2 prospective studies, randomized studies, looking precisely, but they are actually phase 1 and 2, looking at dose de-escalation. So in smaller tumors, whether maybe a lower dose it's enough to keep the local control. And the other one is the opposite, in very advanced tumors, the addition of combinations of immune therapy to the cisplatin systemic therapy. So as you see, there are so many things going on, and in parallel there is also the EMBRACE study that looks into prospectively into the treatment of vaginal cancer. And there are many efforts in the ray radiation setting, including also oligometastasis with external beam, but specific to the brachytherapy. The retrocosmos has a cohort of patients treated with brachytherapy when they have local recurrence in the previously treated radiation. So these are the major things. Of course, in parallel, there are many studies going on regarding different types of systemic therapies. Usually they are in the setting of metastatic cancer, but now there are also some studies looking at the addition of immune therapy in the neoadjuvant setting. So it's a lot of things going on now. Hopefully, and of course, we have to tailor it to patient's factor, and the tumor factors, and of course treatment factors. So to be more precise, there is also a bio-embrace looking at molecular factors that could determine us to take one treatment over the other in cervical cancer as well. But the molecular factors are very well actually researched and implemented in the treatment of endometrial cancer. So many things going on at the moment.
It's like the EMBRACE study keeps having babies. So I hadn't heard of.
Yes, it should be like that.
I
Yeah. So
embrace.
we have to develop ourselves further. Yeah.
Yeah, and actually, we calculated the other day that if you add up EMBRACE 1, EMBRACE 2, retro EMBRACE, you're getting near to 4,000 patients that have been enrolled, which is amazing. It's an amazing number. And apparently it keeps growing, so
It is.
that's fantastic. Alina, I can't resist to ask you a bit more generally about women's cancers, Considering the unique medical and sort of psychosocial aspects of women's cancers, uh, how are treatment strategies evolving to provide more personalised and holistic care, or are they not? And is that something that needs to be a focus more for women's cancers in particular?
Are you talking in prevention or in once they get cancer?
So once they get cancer, so looking at it a bit more holistically, side effects, quality of life, sexual function, things like that maybe haven't been such a focus so far.
Yeah, exactly. Yeah. Oh, thank you for asking that because actually there is a lot of focus indeed on the holistic approach. And actually, it is such in focus that it's included in the European guidelines. We are through the guidelines, we're mandated to refer patients to psychologists, to the sexual rehabilitation programs, because we have a lot of young patients, unfortunately, and this is a big issue for them. And actually, it is a network that's getting enlarged now. If I think back in about 10 years ago, we didn't really have any of this. And now it's getting larger and larger. And the majority of tertiary cancer centers are having at least a sexual rehabilitation program. All cancer centers have a psychologist that's dealing with the emotional part related to having this cancer. And of course, the patient should stay in touch with their doctor in order to address questions that may arise from this or that potential side effects. So I think, and the other thing is that we are trying to also teach family physicians, for instance, or a gynecologist. It depends on the country, but many patients, they are not able to come to the tertiary cancer center for the follow-up. And it is important because some of the side effects of the radiation develop years after having the radiation. So we are trying to also teach regular gynecologist and the family physician to be aware of this. And so it's very important and of the potential treatments for potential side effects. So it's a very growing field, and of course, the purpose is to have these women have a very good quality of life. But let me assure you that seeing so many patients that are including, you mentioned the number of patients in Embrace, in Retro Embrace, Embrace 1 and 2. I think the majority have a very nice quality of life after. And it's so rewarding to see because I've been in Vienna for 17 years. And I've seen recently a patient that was one of my first patients, and she's now 16 years in follow-up, and she has a fantastic life, and it's really, really rewarding to see that.
That must be lovely to have a patient who's 16 years in follow-up. Yeah.
Yes,
Yeah,
yes,
well,
yes.
congratulations for that, for your great work. How did you actually end up specializing in treating gynecological cancers?
Well, it's very simple because I love oncology, I love radiation oncology, but I also wanted to be hands-on a lot. And during my residency training, which happened actually in Canada, in Toronto at Princess Margaret Hospital, I came across brachytherapy, of course, during my gynae oncology rotation. And I fell in love with the brachytherapy, with the fact that you can treat the tumor is so close to the tumor and treat it direct to the point. And then at that time, Professor Pötter from Medical University of Vienna was developing and publishing the first results of the MRI-guided brachytherapy in gynecological malignancies. So I did an observership for a month, and I decided to come here first for a fellowship to learn this and bring it back to Toronto maybe. However, I ended up staying longer because the infrastructure that I had here at the time was not available anywhere else in the world. So this is the way I ended up treating this. Plus, we had an excellent team.
That's great. And I believe you originally began as a student of the Brachy Academy, and now you teach at the Academy clinical workshops in Vienna, Rome, Mumbai. So can you tell me a bit about how that evolved?
Yes, it's true. Actually, yeah, it's good that you remind me of that. I think my first year here, I got acquainted with the Brachy Academy course in workshop in Vienna. At that time, I think it wasn't called Brachy Academy. I think Brachy Academy it's a bit older, sorry, younger than my first year here. So I was an observer of the first one, and then I that was the next one I was asked to teach already. And then I really love teaching. I think it's so important. And I have to say that in Canada, at University of Toronto, teaching was very, very much emphasized. So, and at that time, I realized how much I love doing that. And I think this helped me a lot to become already a teacher with the second Brachy Academy workshop that I attended. And then, as a natural development, I was asked to participate in the Rome workshop in Mumbai as well. And I'm very excited because all the time I have to bring something new, and I like doing that. Plus, the disease that I'm teaching about, diseases that I'm teaching about, different entities of Gani malignancies are different in all these Brachy Academy workshops. The attendees are very different. They have different requirements, different settings in their own countries. You cannot compare the settings in India at the workshop in Mumbai with the settings in Europe. So it's very interesting because I also learn a lot from them, and they learn a lot from me. So it's a win-win situation for all of us.
So would you say that education training has become quite important to you, and maybe mentorship as well? Because you do some mentorship as well, don't you?
Yes, yes. Because I'm now experienced enough,
Mm.
and I've been treating gynae malignancies in the last 17 years. So I gained a lot of experience. So I liked very much to share my knowledge to my younger colleagues and build up a new generation that's also dedicated to brachytherapy in general and gynae oncology in particular. Yes, I'm teaching a lot at these workshops, and in many situations, the students that are participating in the workshop they stay in contact with us, and when they have challenging cases, they write to me and to my colleagues, and we try to help them. So it's not only the teaching at the workshop, but also keeping in touch with our attendees. And the other thing is that I mentioned to you that I'm the lead in the Jack Estro Brachytherapy Fellowship. And part of this is that each fellow has a mentor and a local tutor. So basically, we want to teach the new generation, dedicated people to a different side or to brachytherapy in general, in centers of excellence, which have the ideal setting to study brachy and to have the hands-on. And as I said, these are called centers of excellence. And these fellows have a local tutor that's in charge with their training in the center, in the respective center. And there is also a mentor, which is who is a part of the Jack Estro committee, education committee. And this mentor has really the role of a mentor, meaning that they are supervising also the research activities of these fellows. They make sure that the fellows come into the Czech Gastro Society and further into the Estro, and they are kind of a neutral person in case that something doesn't work very well in the center of training. They can refer to us and discuss with us, and we didn't have until now problems at all, but it's very, I find it very good for these fellows to have a mentor with experience that can guide them in their career further.
I'm going to ask you a little bit about yourself now, if you don't mind.
Yeah.
So, do you see yourself as a trailblazer?
I think so. I think so. Yeah, I'm
I think
trying
you are
to
too.
to be one. Definitely, I'm one in education. Because I felt that there was a weak spot in development of education in brachytherapy, because we are so busy, and uh, we have to take care of the patients. We have to do this and this, to do studies and everything. And I think the education in brachytherapy was a little bit neglected. And with my background from Princess Margaret Hospital and University of Toronto in general, where the education was so emphasized, I felt the need to do something in these regards. And so I think this Euro Brachytherapy Fellowship is more or less my baby. Of course, I have a group that I'm very thankful for, of very dedicated brachytherapists that are helping me with organizing this, and we move forward very fast. And Electa also was very, very important in developing this, because they offered us the first grants for the fellows to go to different centers. So in this regard, I think I'm trailblazer. Uh, in other ways, as I said, I believe very much in brachytherapy, and actually the ray radiation in gynecological malignancies is another topic that's very close to my heart, and I'm trying to develop it further. So yeah, I think I yeah.
I definitely think you are, which is why I invited you on the podcast. But also, I'm pleased that Electa's had a small role in you being a trailblazer as well.
It's not a small role; it's a very important role, I must
Good.
say.
I don't want to put words in your mouth, though.
Yeah.
What would you say motivates you? You're a very busy, effective person. Is there something that keeps you going at the speed that you go at, do you think?
Well, first of all, seeing these patients, I mentioned to you, these patients that are coming 16 years, 15, 10 years in follow-up,
Yeah.
they are very motivating, You see it with your own eyes that you can make a good difference in their person's life, yeah? But you also see the, fortunately, the few cases that have some side effects just because they are tumors who are very large at the beginning. There are some patients with fistula formation and things like that, and you always have to, you learn from your own experiences. You see what could go wrong, but on the other hand, you also know that if you didn't treat those patients, even with the price of having a fistula formation, for which, by the way, you have options of treatment, yeah, then they wouldn't be alive to come to visit you. So obviously this motivation keeps me going. I'm a very social person, and I like, not necessarily making an impact of somebody's life, but as I said, I go back to my Canadian experience. I am so fortunate of having trained there, because what it was amazing at University of Toronto, all the radiation oncologists were trying to give us their best to teach us to be very good doctors, and I learned from them that I have to do that, and I saw the benefit of doing that. So that's why I'm trying to give further what I learned, and to guide our new generations, in a way, on if they are interested in brachytherapy, on that paths and so on. So I think it's very rewarding for me to do this. And as I said, I love brachytherapy. I love the hands-on experience. So I'm never bored, believe me. So these all are getting me, going further. Yeah.
I love that. So you're sort of paying it forward, but also I can imagine that if there's a student around you, they couldn't help but be influenced by your enthusiasm for brachytherapy as well. That's great.
Yes. I mean, you really have to like it, because it takes a lot of sacrifice. You have unpredictable hours, because if your brachytherapy is not ready in time, you have to stay longer. Your colleagues are long gone, but you have to stay here.
I do remember those days.
Yes, absolutely. Yeah, I agree with you. I'm sure you do remember. But it's very nice. I mean, but you have to be prepared to put up with this, of course. Yeah.
So you mentioned you're a very sociable person, which I love to hear from a radiation oncologist. But I wondered, do you get time to socialise?
Yes. I try to. I mean, it's getting worse, but I try to. And what I meant by socializing is, for instance, now, because we have a bunch of fellows, I meet them at all these congresses, and that this makes me so happy. We go out at least once to congresses, and the group is getting bigger and bigger, and that's fantastic.
That's nice. That's nice. Yeah. And maybe you don't have time for this at the moment, but do you have any hobbies or interests that might surprise your students or patients?
I don't know whether they would surprise. So, believe it or not, I love fashion.
Yeah. You love passion?
Fashion.
Oh, fashion. You come across as very trendy to me. So, I don't think they would be surprised by that.
Yeah, I like, painting, not necessarily myself, but art. I liked arts in general, and painting is one of my favorite arts. And what might come surprising is that when I was younger, I played saxophone. Yeah, so I don't do that anymore, because it's very loud, and you have in Vienna, you have to go to special places to exercise. So I don't have time for that. Yeah, and I like going out and meeting friends, and I mean, nothing surprising, I think.
Oh. Saxophone is an art form in itself. There's a colleague here, his name's Roberto Pellegrini. He plays the saxophone, and he quite often travels with it. But it's quite a dedication to, taking it with you and practicing, isn't it? Yeah.
I think would be difficult for me, because I'm very busy when I'm going away. Too many meetings and things like that. But it's nice, when I will have time when I get older. So probably I'll go back to that.
Well, talking of being very busy, I'm going to let you get back to your busy clinic. But I'm super grateful for getting an hour of your time today, and I've really enjoyed talking to you, and I've definitely learned a few things. And hopefully, someone who's listening will not, can't fail to be enthused by your passion for brachytherapy as well. So thank you very much.
Thank you very much for inviting me and giving me the opportunity to show up my passion, to share it with people that don't know me, but maybe, who knows, I may influence them indirectly, either to go for brachytherapy training or just to have brachytherapy as treatment.
Yeah, there's more friends coming your way, definitely.
Thank you so much.
Thanks, Alina. Thank you so much. If you enjoyed today's episode, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.